morning. I am happy to hear. Thanks, Dr. Ravichandran, the scientific committee and the organizing team. Acute coronary syndrome is a wide spectrum, starting from unstable angina, non-ST elevation MI, and STEMI. We have to think invasive management as well as conservative management depending upon the situation. It is defined as ECG changes, rise in cardiac enzymes, imaging evidence such as regional wall motion abnormality, and the basic pathology is nothing but plaque rupture presenting with thrombus. When compared to chronic stable angina, here there will be thrombus. It's not only the plaque rupture that is commonly seen in males, which is rich in macrophages and lipid-rich core. There may be an underlying pathology of plaque erosion, which is common in females, which is loaded with neutrophils, and it is collagen-rich. In plaque rupture, there will be smooth muscle apoptosis, whereas in plaque erosion, there is endothelial apoptosis. And the treatment is entirely different. How to approach a patient with a non-ST elevation MI or unstable angina? The difference between unstable angina and non-ST elevation MI is nothing but the evidence of myocardial damage will be seen in blood, that is rise in cardiac enzymes. And if there is associated cardiac failure, we can see the rise in pro-BNP, and there will be associated dyslipidemia. There may be associated renal dysfunction, diabetic status, and acute coronary syndrome being an inflammatory condition, we can see rise in hsCRP. How to risk stratify unstable angina or non-ST elevation based on these criteria, that is elderly patient, associated coronary artery risk factors, patient is on aspirin, patient having ECG changes, patient having elevated cardiac enzymes, patient is having rest angina in the past 24 hours, and documented evidence of coronary artery disease in angiogram. If these patients, these risk factors are present, we can categorize these patients into low risk, intermediate risk, and high risk, and this will help in the prediction of mortality rate. And based on the high risk, very high risk patient, we can go for aggressive invasive therapy. That is, aggressive invasive therapy is in the sense, immediate invasive therapy, within 2 hours we have to take him to the cath lab. If these features are present, if the patient is having cardiogenic shock or malignant arrhythmias, post-cardiac arrest or ST elevation, like that. Whereas if he is having less risk factors like ST depressions, resuscitated cardiac arrest without shock, or dynamic ECG changes, we can take a little bit time, that is, we can do the CAG in 24 hours. If a patient is presenting to a non-PCA center, we have to refer him immediately if he is a very high-risk patient, or within a day if he is a high-risk patient. And ST elevation MI is nothing but ST elevation in more than 2 contiguous leads, except V2 and V3. And V2 and V3, there should be increased ST elevation of more than 0.25 in men less than 25 and 0.15 in women. Whereas in other leads, even 0.1 millimeter elevation in 2 contiguous leads is adequate to make a diagnosis. Apart from presence of pathological cuveus, regional wall motion in echo, and coronary thrombus in angiogram. And STEMI has a highest mortality when compared to non-STEMI or unstable angina in the form of 5 to 7% in the initial hospital stay, or up to 18% at 1 year. What are the types of MI? There is a universal definition of acute myocardial infarction. There are 5 types of MI. We commonly come across this type 1, which is related to thrombus. The second thing is arterial demand supply mismatch. The third one is any death with suspicion of MI. The fourth one is PCA related. It may be 4A, that is during the PCA or immediately after the PCA 4B or late stent ISR. And the type 5 MI is MI happening in a patient who has undergone a CABG. And there may be atypical ECG findings that may present with MI, that is LBB, and you can apply the Scarbosa criteria. Or there may be ECG findings in patients with RBB or LBB following a paced rhythm. And we should not miss RVMI, especially in patients with inferior MI. That is, RVMI can happen in 50% of patients presenting with inferior MI. And isolated RVMI is quite rare. It's just 3 to 5%. And we have to load with adequate IV fluids if the patient is having an RVMI, in contrast to anterior MI. And we should have a watch on atrial infarction, which can precipitate atrial arrhythmias. Atrial infarction can happen in 5% of the population in isolation and 15% of the patients presenting with LVMI. And it's more common on the right compared to left. And anticoagulants of choice is conventional unfractionated heparin, the dose of 60 units per kg bolus and followed by 12 units per kg per hour. Or else you can have a low molecular heparin at the dose of 1 milligram per kilogram subcutaneous BID dose, provided the creatinine clearance is adequate. If the patient is having a renal dysfunction, we are better to use unfractionated heparin. You can take the chance of using fondaparinux, keeping in watch if the patient is not immediately undergoing cath, because cath-related thrombosis can happen in fondaparinux. And bivalent can be used if the patient has developed any HIT, heparin-induced thrombocytopenia. These are the loading doses that can be given in the setting of ACS. Aspirin up to 300, clopidogrel up to 600, prasugrel 60 milligrams, and cangrelor bolus of 30 mics per kg. And these doses need not be reduced in the setting of associated renal dysfunction. And the maintenance dose per se for aspirin, a low dose of 75 to 150 mg. And the loading dose, the aspirin continuation dose should be 75 mg if the patient is on ticagrelor. Whereas clopidogrel 75 mg, prasugrel 10 mg, and ticagrelor 90 mg BID dose are the maintenance dose for these patients. A word about heparin-induced thrombocytopenia. We commonly use heparin. Not only this unfractionated heparin, even your low molecular heparin and few other drugs like clopidogrel or ticlopidine. The use of IABP, all this can cause thrombocytopenia during your course of stay. If the patient develops HIT, that is heparin-associated thrombocytopenia, which occurs earlier, you need not stop heparin. Whereas if the patient develops an immune-mediated heparin-induced thrombocytopenia, here there will be associated thrombus with the thrombocytopenia. The type 2, which is allergic or immune-mediated, that is fatal, and it can result in acute stent thrombosis also if the patient has undergone a PCI. And there are 4 T's to diagnose HIT2, that is thrombocytopenia or timing of platelet, thrombosis, and other causes of thrombocytopenia being ruled out. What is the strategy of prescribing lipids, anti-lipid lowering agents? If the patient is on high dose or a low dose statin, convert him to high dose, high intensity statin. The patient is on low dose statin, convert him to high dose statin, and make sure that the patient LDL level is less than 55. That is a recently set goal to manage patients with ACS. The patient is not getting controlled with high dose, high intensity statin. That is, he is not reaching the goal of less than 55, you can add ezetimibe. As physicians, we commonly use the reperfusion strategy. When to thrombolyze a ST elevation MI patient. If the patient is presenting within a period of 12 hours, the best thing is either PCI or thrombolysis. Up to 3 to 6 hours, the plaque will be usually a white thrombus which is amenable for thrombolysis, you can do thrombolytic therapy. But after 6 hours, up to 12 hours, you can thrombolyze, but the efficacy will come down. Whereas in such patients, PCI scores over after 3 to 6 hours. And if it is more than 12 hours, there is no option for thrombolysis, it is only PCI. And moreover, if the patient is having a cardiogenic shock or a very much high electrical instability, or patient has developed some mechanical complication, no other go, we have to go for PCI. And more than 48 hours, there is no indication for a PCI, especially in patients without any symptoms. The patient is having symptom, you can attempt PCI in patients presenting after 48 hours. This is the ESC guidelines 2023, the latest guidelines when to thrombolyze. And the first bolus always prefer a fibrin-specific thrombolytic agent, which will be which will have more efficacy and less antigenic. So better go for either tenecteplase or retiplase, which have a high coronary artery patency rate compared to streptokinase. And the first bolus should be given within 10 minutes, whether if you have made a judgment to thrombolyze the patient. And if it is more than 75 years, the patient is an elderly patient coming to us with a STEMI, you can give a half-dose thrombolysis. You can give half the dose of either retiplase or tenecteplase, and this is class 2A indication, whereas the full dose in other patients is class 1. Still, you can use half the dose. In elderly, age is not a limitation for thrombolysis. And you have to take the risk of ICH. Aspirin and clopidogrel are recommended. This dual antiplatelet therapy is more efficacy than a single antiplatelet, especially in ACS setting, because of resistance, either aspirin resistance or clopidogrel resistance. The common causes of aspirin resistance are nothing but entry-coated aspirin or overexpression of COX-2 mRNA. Whereas clopidogrel resistance, it may be due to genetic polymorphism. And adding clopidogrel to aspirin will give additional protection by about 30%. So always combine the dual antiplatelet. But after the advent of ticagrelor, which is more potent and reversible inhibitor of platelet, the role of clopidogrel has come down. And you have to anticoagulate the patient either with unfractionated heparin or low molecular heparin, as previously mentioned. You can choose fondaparinux, but it has a less indication compared to low molecular heparin or unfractionated heparin. These are the common complications of like thrombus happening in a patient with LV dysfunction, or a ventricular septal rupture happening. All these things will happen in bimodal presentation. Either it will happen in the first day or 3 to 5 days. All these mechanical complications will worsen the outcome, and we have to intervene either by modern devices, or we have to get the help of the surgeon. A word about true and false aneurysm. False aneurysm happens due to rupture contained by pericardium, whereas true aneurysm is due to the apical bulging. Both can lodge a thrombus. And common arrhythmias which we come across is atrial fibrillation up to 15%. If the patient is having a hemodynamic instability, you have to give DC shock. In cardiogenic shock, the routine use of IABP has come down to class 3, and you have to do early PCA or CABG. And a word about MINOCA, that is myocardial infarction patient with non-obstructive coronary artery disease. There are various presentations, either due to plaque rupture or erosion or vasospasm microvascular dysfunction, which is more common in females and it doesn't require stenting. And few patients can have spontaneous coronary artery dissection. Dissection can be managed conservatively, And you commonly come across such ECG like diffuse ST elevation in non-obstructive CAD, and this is due to a condition called stress cardiomyopathy. It presents like a MI-like pattern, commonly come across. This is a patient with a 75 years stroke. And never ever hesitate to do repeat ECG. This is a ECG of a patient taken at 11 a.m. in another center. Patient was referred with a typical angina, and I was about to do treadmill, but on the unstable angina we should not do treadmill, but I took the chance and I found acute MI, immediately thrombolized and LAD was opened. So we need not hesitate or we need not be reluctant to treat ACS. With adequate training and skills we can manage. Thank you.
Thank you very much for the detailed